Welcome to Chapter 5, Measurement and Sampling. This chapter introduces one of the most critical components of program evaluation and effectiveness: how we define, collect, and analyze data. Let's begin with a basic question. What is measurement in public health? Measurement is the process of applying numerical or narrative data to concepts, behaviors, or characteristics in a consistent and objective way. Why does this matter? First is, measurement helps determine if a program is working. Second is, it transforms abstract ideas like stress or satisfaction into measurable outcomes. Third is, it allows comparison across populations, time, and interventions. To measure effectively, we need to define what we're measuring. This brings us to two foundational concepts and constructs. A concept is a general idea like self-esteem or health literacy. A construct is a concept that has been deliberately defined for measurement purposes. For example, physical activity becomes a construct when we define it as 30 minutes of moderate exercise 5 times a week. Next, let's look at variables. A variable is the measurable form of a construct. Variables can take different values, and they are what we actually collect data on. There are two main types of variables: independent variables, the ones we manipulate or categorize to observe an effect. Dependent variables, the outcomes we measure to see if they change based on the independent variable. Once we define our variables, we must decide how to measure them. There are two broad categories of data: quantitative data, expressed as numbers like blood pressure, BMI, or test scores; qualitative data, descriptive, narrative, or observational, such as interview transcripts or open-ended survey responses. Quantitative data can be further broken down by level of measurement. First is nominal, categories without any order like gender or blood type. Second is ordinal, categories with order like satisfaction ratings from 1 to 5. Third is interval, numeric scales with equal spacing but no true zero like temperature in Celsius. Fourth is ratio, numeric scales with a true zero like weight or number of doctor visits. Understanding levels of measurement is important because they determine what statistical tools we can use later. Now let's discuss reliability and validity, two key concepts in ensuring quality measurement. Reliability is the consistency of a measurement. If a tool gives the same result over time or between observers, it's reliable. Types include internal consistency. Do items within a tool measure the same concept? Test-retest reliability. Is the result stable over time? Iterator reliability. Do different observers agree? Validity is whether the tool measures what it is intended to measure. Types include face validity. Does it appear to measure the right thing? Content validity. Does it cover all aspects of the construct? Construct validity. Is it consistent with theoretical expectations? Criterion validity. Does it correlate with an external benchmark? Reliable tools are not always valid, but valid tools must be reliable. Both are needed for trustworthy data. Next is instrumentation, the actual tools and procedures used to collect data. Examples include surveys, scales, observation checklists, and laboratory tests. When choosing or developing an instrument, consider readability, cultural appropriateness, and ease of use. Now let's shift to sampling, how we select people to participate in our data collection. Sampling matters because we can rarely measure an entire population. Instead, we study a subset of the population. If chosen well, the sample reflects the larger group. There are two major categories of sampling. Probability sampling, every member has a known non-zero chance of selection. Examples: simple random sampling, like drawing names from a hat. Systematic sampling, every nth person on a list. Stratified sampling, dividing into groups, then sampling each group. Cluster sampling, randomly selecting whole groups. Non-probability sampling, not every member has a known chance. Examples: convenience sampling, choosing whoever is easy to reach. Purposive sampling, selecting based on specific characteristics. Snowball sampling, participants recruit others. Quota sampling, sampling to meet preset group numbers. Probability sampling is best for generalizability, but non-probability methods are often more practical and common in field settings. Next is sample size. Too small and your results may not be accurate. Too large and you waste resources. Use power calculations, budget limits, and design complexity to guide your sample size decisions. Let's not forget about ethical considerations in measurement and sampling. Participants must give informed consent. Data should be confidential and secure. Sampling should be fair and respectful, especially in vulnerable communities. Finally, let's summarize. First, measurement transforms abstract concepts into measurable data. Second, good measurement requires reliable and valid tools. Third, data can be quantitative or qualitative, each with specific strengths. Fourth, sampling determines who participates and how well the data represents the population. Fifth, ethical practices must guide every step of the process. Thank you for watching this video. This concludes Chapter 5, Measurement and Sampling. Based on planning, implementing, and evaluating health promotion programs by James McKenzie, Brad Neiger, and Rosemary Thackeray. Stay tuned for Chapter 6,